right, our next speaker is Dr. Luciana da Fonseca da Silva, and she'll be sharing with us our global results with the da Silva cone repair. Luciana.
Thank you, Jack, for the presentation again. And thank you, everyone that presented already. We really appreciate your effort to make this event great. So I will present our results with the da Silva cone repair. And when we talk about the da Silva Center for Ebsen's Anomaly, obviously we think about Dr. José da Silva that created the cone procedure, and myself that was with him since the beginning in the first cone operation. I was there as a first-year resident. But we are bigger than that. In 2016, Dr. Victor Morel, chair of the Department of Cardiothoracic Surgery at the UPMC, created the da Silva Center, inviting José da Silva to come here. And with all the support of Dr. Jack Kreutzer, the chair of pediatric cardiology here at the Children's Hospital. And this da Silva Center involves a huge team of APPs, coordinated by Erin Colvin and Kate Scollon, many cardiologists. Some of them are here in this picture, some of them presented today. The anesthesiologists, the nurses, the anesthesiologists, research, intensive care people, the heart catheterization people, the electrophysiologists. So it's a huge team devoted to make the best for our patients and to prolongate the life of the Ebsen's anomalies. But we need to understand that the history of UPMC with the Ebsen's anomaly comes from a long time ago. Dr. Benson here, before most of us were born, he was already doing some cone repair here. So in 1965, he presented 3 cases where he did a cone repair using the Hunter technique. And later on, together with Dr. Zuberbiller and Dr. Bobby Anderson, they made a lot of studies on Ebsen's anomaly morphology to better understand the anatomy and the surgical repair. When the cone was created in 1993, the most used technique for tricuspid valve repair in Ebsen's was the Danielson technique, but we need to understand that that technique was not applicable for all the patients. So in this paper published in 2006, demonstrated that most of the patients, children, they received a replacement of the valve, and that would mean that they would need severe more replacements during the life, like that lady that we showed before. Another technique that was a monocuspid technique was the Carpentier technique, but with a high mortality and still need for replacement. And those monocuspid techniques were not applicable for those patients with severely rotated tricuspid valve. So that was the reason to postpone the case to adult life without operating. And in 1993, Dr. da Silva created the cone procedure that involved the full detachment of the leaflets of the tricuspid valve and the creation of the cone. And in the first patient, he didn't detach very well. The leaflet was a severely displaced valve. And then 4 years later, we need to go back and redo the operation. But that was the first case. And then after that, we start doing more aggressive work in the valve, removing the leaflets where they were positioning, bringing to the true tricuspid annulus. So this technique, the cone repair, is applicable even to those severely rotated tricuspid valve. So here we have a case in the bottom part where we are demonstrating in this figure here, in this drawing here, where the valve was rotated. So with a lot of work and rotation and sutures, we are able to bring the valve to the right position and construct a competent valve. Here is one case of a severely rotated valve. You can see here, the valve is completely in the RVOT, and then the operative result is really good. And this is the echo showing the trivial regurgitation in the tricuspid valve. And the cone repair, the Silva cone repair, is applicable even for patients with hypoplastic septal leaflet. We can rotate the valve if we have enough leaflet to create a competent valve. But in some cases, we need to do leaflet augmentation, and usually we do it in the septal area. Here we can see a piece of autologous pericardium patch that was applied in a higher position to make some adjustments to the cone to create a competent valve. And using that patch showed a good result. We also demonstrated earlier that we can do tricuspid valve repair after the stance procedure. This is a case that was showed multiple times today, demonstrate that it's possible to do the cone repair after the stance procedure and even after the Fontan procedure. We also published the case of tricuspid valve replacement. After tricuspid valve replacement, we published 2 cases, now we have 3. And our center here at the Children's Hospital has an increasing number of patients every year. So at the beginning it was a small number, but of course people need to know the expertise of the place. And then after I arrived, the number went up. That is part also of the social media, because most of the patients, they are referred by themselves to our service. And then when the cardiologists know our service, receiving the patient back, then they start sending the patients to us. Here are our global results. We have now, with the patient that we operate this week, an adult patient, we have 147 patients. 25% of them are adult patients, and we have 0 hospital mortality for all the cohort, and we need to do a late valve replacement in one patient, and another one we know that had a replacement at another center. Heart transplant was needed in one patient. Late deaths occurred due to a brain tumor in one of the adult patients. Among the children between 13 months and 18 years of age, also no mortality. We had a patient that we need to do a stance after the cone, so the opposite also can happen if you have a severe right ventricular failure, and one heart transplant. And 2 late deaths. One, it was a liver disease complication, was a patient, a cone after stents that came to us with already some neurological damage and a liver disease that would require a liver transplant. We did the cone after stents. She survived, went well to home on her tracheostomy, but she had a complication of the tracheostomy at home after some months, and then she passed away. But the heart was working perfectly even after the arrest at home. And one patient complicated in another hospital due to liver bleeding during a heart catheterization in another hospital. In the first year of life, we have 12 patients with 0 hospital mortality and no late deaths. We present also the 19 patients with the cone after stents. 2 of them were done in Tampa. Regarding arrhythmias, our cardiology fellow, Brooks, he presented at the heart rhythm yesterday, the data regarding the EP study that is performed here and the treatment of WPW and supraventricular tachycardia. So surgical ablation was performed among 135 patients. We performed surgical ablation 64% of the patients, and most of them were cavo-tricuspid isthmus ablation to prevent future supraventricular tachycardia. Regarding device implantation, we had 7 pacemakers implanted. That means 5% of the patients required a pacemaker, but only 2 of those patients did not present any PR conduction disturbance in the pre-op. That means if the patient has a first-degree heart block or second-degree heart block, the chance to need a pacemaker will be a little bit higher, but it still is a low number of patients that require pacemaker in our center. Here is the tricuspid valve function. Thank you, Vina, for acquiring those data in our patients. Most of the patients presented a moderate to severe regurgitation in the pre-op, and most of them, around 9% of them, will show non or trivial regurgitation or even mild regurgitation in the post-op. And this is maintained in the most recent echo. This is considered a great result. But however, the function of the right ventricle is a little bit depressed immediately after it starts. But we need to remember that Ebstein's anomaly is a failure of the lamination of the tricuspid leaflets from the myocardium. And preoperative, some patients has also some compromising of the right ventricle that's not well demonstrated due to the RV, the tricuspid valve regurgitation, and that will be unmasked in the post-op echo. And also because the patient has the atrialized portion. And when we reduce the tricuspid valve regurgitation, we can have more dysfunction. In our center here, we are doing research at the UPMC, Dr. Guang Li and Dr. Ivy. They are doing extensive research at the molecular level to understand better the deficiency in Ebstein's anomaly. So they are using patient-derived induced pluripotent stem cells, and they demonstrate already that the myocyte proliferation is decreased in Ebstein's anomaly patients, and the cell death is increased in patients with Ebstein's anomaly. And this study can help to clarify why some patients present severe RSV dysfunction, and this also will open new pathways for medical treatment, hopefully. So in conclusion, the cone repair is effective and durable with rare need for tricuspid valve replacement, even in severely rotated valves. The newborns with critical Ebstein's anomaly can benefit from a staged approach, as demonstrated before. The cone repair after prosthesis is possible to do if the leaflets were preserved in previous procedures, and the right ventricular dysfunction is in Ebstein's anomaly still requires further investigation and treatment improvement. So I would like to thank you, Dr. Morel, for creating the Da Silva Center, Dr. Jack Kreutzer, Erin Colvin, and Kate Scollon for all the support that you give to our team, and also to all the presenters today and for the people that are helping us to deal with Ebstein anomaly patients and to have those great results here in our center. Thank you so much.
Thank you, Luciana. Anyway, we'll come to the end of our symposium, and obviously, I hope everybody had a great time. I hope everybody learned something new during our sessions. I hope it's palpable that there's a tremendous commitment here at Children's Hospital of Pittsburgh, of UPMC, as it relates to the management of patients with Epstein's anomaly. We're trying to push the boundaries of care. If you look at lesions in congenital heart surgery over the last 10 years, I would argue that the biggest progress that has been done surgically is in Epstein's. And the fact that, at least here in Pittsburgh, we believe that maybe, I wouldn't say 100%, but the majority of patients with Epstein's could achieve 1.5 ventricle or biventricular repair. And I think that the data that we presented today sustains that concept. We also believe that patients, neonates, probably should not have a cone procedure done. It's probably not a good first operation as neonate. There's really very little data. We know it has high mortality, and we really don't know. There's really no paper out there that looks at patients that had a neonatal cone and look at the long-term outcome, long-term results of the valve function. So those who did survive the cone, we still don't know if those valves are functional long-term. It makes more sense if you have a sick neonate to do a Starnes and then follow with a cone at a later time. It is very reproducible, and obviously what we've shown from our outcomes, it's, the outcomes are terrific. And clearly, this comes from concepts that Jose and Luciana have had for a long time, and we keep pushing the boundaries, and I'm sure next year, I can't believe this is the 5th symposium, or at our next symposium, I'm sure we'll be presenting something else that maybe it's never been done before, but that makes sense and hopefully keeps advancing the care of these unique patients. I want to thank James Ferris for his contribution every year to our symposium and making all this happen. Obviously, there are members of our team here who, without their support, this wouldn't happen, and we want to thank you guys for terrific work that you guys do in putting this symposium together. I know it takes a lot of work, dedication, commitment, and without you, this wouldn't be possible. Okay, and I hope that we see all of you next year or the year after. We have to decide when the next symposium will be, but certainly there'll be another symposium. And please reach out to us. You have any questions, you have referrals, anything we can help, we're more than happy to give you our thoughts, ideas on the management of these patients. And if you happen to have some interest in that maybe we're not aware, please reach out and let us know. We would love to keep advancing the care of patients with Epstein's anomaly, okay? Everybody have a good rest of your day, and thanks for logging in. Thank you.